Welcome everybody. Well done for joining us for the next in our series of lightning lunches. We're finding this format of a half hour at a lunchtime to be very acceptable to people and useful. We hope it will be useful today. My name's Andrew Knight. I've probably met some of you, if not all of you, or come across you over the years in the improvement game with the Improvement Foundation, and it's great that the Improvement Foundation is continuing their commitment to staying in touch with us and keeping us challenged with ideas. And today's idea, I think, is a beauty. We all know, I think, that aged care can be very challenging. Visiting aged care facilities and providing care in aged care facilities can be a frustrating experience for GPs. And unfortunately, it means that some of our most vulnerable members of society miss out on care. The first step of an improvement program is to identify a problem. And this is something that Joanne has done. And I guess the first time I met Joanne, Joanne was it last year when you put in an application for the Improvement Awards. And I was really impressed by that application. Joanne has the ability, in that case she saw a problem, or she started off on the problem of coding, and she followed that coding problem down a path which led to a huge change across the whole practice as she dealt one by one with the issues of coding and systems and practice registries, and then through quality improvement and CKD. So it's no surprise to find that Joanne is applying that kind of approach to a new problem. In this case, the problem of aged care and the challenge of providing that in her locality. I'm not going to go on. I'm going to introduce Joanne, who's going to speak to us about how this problem led her to a whole program of improvement in the practice. I know others of you who are listening have also identified the problem and done some improvements as well. So hopefully this is going to be a really useful thing for you for addressing this really difficult challenge for our GPs and practices, but more particularly for our patients in aged care facilities. So Joanne, over to you.
Thank you, Andrew. Thank you, Alison, too. We identified a problem in aged care a little while ago when we rang a few nursing homes to see if they would like a doctor to come and help them. And when we made those phone calls, we found out that there were a lot of nursing homes who didn't have doctors, who were desperate to have doctors. So we started looking at how we could help them and how we could get doctors to do this. And it was a bigger problem than we anticipated. What we realised is that, you know, aged care is something that isn't just in the nursing homes or hostels. It's for people at home. It's the patients who come into the surgery. They could be chronologically or physically aged. It's a really, really big problem to get the care out there for all these people. So, like it or not, we've realised that this is a real growth market. There's a big opportunity in your practice if you want to get into aged care, and it's a stable population with a steady income stream. In aged care, general practice is a speciality. It's cradle to the grave care, and we really shouldn't be abandoning our patients just because they get old. The government is changing things so that the aged are kept in their homes and there's less time to be kept in hospitals and aged care facilities. So why don't the doctors want to work in aged care? And there's a number of reasons, but there's not a lot of money in it. It can be time consuming, and it may not be high-end or glamorous, but it can be satisfying. Using medical skills, looking after someone who has something wrong with them, with everything in their body. However, some of the doctors don't view this as boring stuff. They just consider it to be like constipation, confusion, falls, all the boring medical stuff. So it's really hard to get doctors to want to be involved in this. Could we go to the next slide? Sorry. Alison, could we go to the next slide? Sorry. So what we found out is with the demographic info that age between 65 and over, as you see here, the population is expected to rise from 3.2 million from the 30th of June 2012 to 5.7 to 5.8 million in 2031. So we've got a lot of people out there who are going into nursing homes, who are in their homes, who need care. It's booming, unfortunately. So next slide. So there's not a lot of money. You have to bulk bill. It's time consuming. And there's a lot of other difficulties with getting leave and dealing with the patients and their families in the nursing homes. Next slide. There's a lot of work involved in paperwork. And I'll go into it a bit later, we've worked out a whole number of ways to reduce that paperwork and to make it a better situation for the doctor. Next slide. So how do we remove those barriers? We basically want to deliver effective, safe, patient-centred care. We can create responsive and organised teams to help our ageing population when they need us the most, and make sure they're not left behind. In order to do this, we need to make a reasonable income to make it worth the doctor's time and effort. Next. So you need to get your time right. You need to book your patients effectively. You need to make sure you've got everything set up so that you're doing what you need to do when you need to do. We have arranged with our admin, we have spreadsheets to do all of this, and I'll go into that a little bit further down the track, how we manage to get all of their care plans, their health assessments, and to get a maximum income. Next. So medicine reviews do make a lot of money if you've got a number of patients in a nursing home, but they also make sure that you're looking after their medications. We have a doctor who's gone into one of the nursing homes, and there's a whole lot of medications these patients have been on, and she's gone and revised all that and reduced a lot of their medications, and these patients in aged care are actually coming through, and they're telling the doctor that it's made a difference to their life. They feel better, they have better quality of life because they're not on all these medications that are just not necessary. Next one. So we have registrars. We are supporting our registrars, and we're giving them nursing homes to work in as well. The registrars get a lot of education from the doctors here because we manage 7 nursing homes at the moment. Well, we don't manage them, we work at 7 different nursing homes. So we're getting our registrars to get that education and understanding of how to look after the aged, and that helps us as well with the management of these patients. Next. So these are the incomes you can get from working in a nursing home with the doctor's income. So we do a health assessment. We do the contribution to the nursing home care plan. They get their medicine review. They still get their 5 10997s, and they get a visit once a fortnight unless there's an emergency. And then you still get your 10991s. That gives us an income of $78.04 for every 20 minutes per patient. Next. We don't have a nurse practitioner, but if you had a nurse practitioner, we've got a similar setup here where you would be getting $75.75 for the nurse practitioner to do those visits, and the doctor would need to do 4 visits per year unless there were other urgent ones. Next.
Joanne, can I ask you a question?
Yeah.
Melissa Clifton's asked for just a little bit more explanation about the provider number issue. Could you just very briefly explain what you were meaning about the importance of having a provider number for the individual nursing homes for each doctor?
Okay. So we, with the provider numbers, we get a provider number for each nursing home for the doctors. So they're based for that nursing home. And what that means is that it doesn't affect our PIP back here at the surgery. So if we've got patients who are diabetic and you're not getting their eye checks done because it's just not reasonable to do, it doesn't affect the PIP at the surgery because it's measured from the provider number based at the facility. And it's the same for, there wouldn't be a lot, but we do have a number of patients who are under 69 years old who are not having their PAP test done for obvious reasons. and so that doesn't affect that. So all of our nursing homes have their own provider number, so our PIP is not affected at all, and we can still get the maximum income for our PIP in the surgery.
Thanks, Joanne.
Yeah.
Keep those questions coming via the chat pane, and we'll try to make sure that we get them answered. Thanks.
Sorry. So the next slide is the income we get per patient for a home visit. So with a home visit, we do the full health assessment, which takes a lot longer, and we do all the other visits. And that works out, when you combine all that, to a 30-minute visit once a month at $157.71. Our home visit patients here get a home visit every month. They don't have to ring in for it. The doctor just goes out. We're starting to do private billing now, so that would actually increase. This is all bulk billing figures. But for all new home visit patients, because we've actually reached our capacity, we do have a lot of home visit patients. The hospitals are referring to us because they know we do that. So we've now decided to start charging that privately because we just can't maintain it. The next slide is if you had a nurse practitioner to do the same thing, if the nurse practitioner was going out to the home to visit them. So next slide is, so how do we get our doctors upskilled? We do a lot of in-house training. We get talks from local geriatricians. We do the MPS talks. Medicine reviews give us a lot of information about our patients, obviously. And then you've got things like the health pathways, which has got a lot of great information on it. Next slide. So that's just about the difficulties that you have with patients. So we use the ISBA, where our Medicare locals won an award using the ISBA going into nursing homes, where they identify the problems, they look at the situation and the background, they do an assessment and a recommendation. And it's really made things a lot easier in the nursing homes. With dealing with the nursing homes, they're often understaffed and overworked. So that has helped to give us clear expectations of what our expectations are and what they expect from us. And we also make sure that all of our patients, whether they've been in nursing home or home visits, even the ones that come into the surgery, who are over a certain age or have certain conditions, we're getting their end of life choices done with them. We talk to them about that. The nurse will discuss with them what their choices are and speak to their family, and we get the forms filled in so that we've got that there. And when it comes to that time, we don't have to deal with asking people the hard questions at the worst time. Next slide. So the support that we have to make all this work, we have our after-hours surgeries, and for holidays we try to get the other doctors in the surgery to look after them, but quite often we find that the doctors in the nursing homes will help support our GPs when they're on holidays, because they know it's so difficult to get that backup support. Now, what we do to reduce the workload for the doctors is we have our admin and our nurses support all of the work that needs to be done. So the admin will have a spreadsheet for all the patients in the nursing home. In that spreadsheet, it will have all of the health assessments when they're due, the care plans when they're due, medicine reviews when they're due. For some patients who we're seeing at home, it'll have when their diabetes cycle of care is due. Even some patients who are in the nursing homes will be on a mental health care plan review. We know when all of these things are due, and we make sure they're done at that time so that we can maximise the income and we can get all the information we need to give better care to these patients. So we have that spreadsheet for that. The pharmacy will fax through all the scripts that they need, and our nurses will grab that list of scripts, and they will produce those scripts, give them to our GP. Our GP will check them and sign them, and they get sent off. Our nursing homes are well aware of how we work. We send an email at the beginning of the week. They know that the doctor will be in on Thursday, and they have to, by Wednesday afternoon, let us know who the doctor will be seeing, unless there's an emergency, of course. And the doctor knows what they're doing and who they're seeing before they get out there. If they need a medicine chart done, the doctor will type that in so there's no confusion with the doctor's writing, which has been a problem in the past where people are misreading it and medications aren't getting done correctly. So we do that with the medicine charts. We know what who the doctor's seeing. We have a list of who the doctor's seeing. If the doctor comes back and they haven't put all the correct billing in, then we know to check with the doctor, did you see this patient? So we don't miss out on any of those billings. So we're getting our maximum income through that. The doctors, the admin, and the nurses are doing a lot of support to help the doctors so that they're basically doing the care and we're doing all of that other stuff that we can do and they don't have to worry about. Next slide.
I'll ask you a couple of questions that are coming through on the chat page. Home visits and care plans at home, are they done by nurses or doctors? And second of all, how do you type the medication charts?
Okay. The home visits, the nurse goes out and she will do the health assessment and she will do the care plan at the same time. The other care plans, quite often we'll send the nurse out and she'll do a whole lot of care plans. We generally have an hour for a health assessment when the nurse goes out. If they're just going out to do a care plan review, they'll have that half hour and they can do them relatively quickly. Or sometimes the doctor themselves will say, I can actually do that and I'll come back and give the nurse some things to do. So that depends on what the doctor wants to do at the time, but more often than not it will be the nurse that is sent out to do that. And that is better use of time, we find, for the nurse to do it than the doctor, and then the doctor just does it next time they're there for the visit.
And most medical software has the ability to generate a medication list just out of the medical software, don't they, for a nursing home? Is that correct?
Yeah, that's right. Yeah, and yeah, so with the medication list, but with the medicine chart, we actually have it as a Word document, so the doctor can type it in.
Okay.
So they can just put that in and send it off. Yeah. Now, what we have done, which is a little bit different, and I'm not sure if anyone else has done this, because it's so hard to get doctors to do this work, we actually applied to have the nursing homes, when we realised how many of them were, to be listed as an area of need nursing home. To do that, we had to get a letter of support from each of the nursing homes, and we submitted an application through to have area of need for each individual nursing home. Now, we did that for about 10 nursing homes, and there was only one that was declined, and the rest we got that approval for. So we then were able to advertise for an area of need doctor. We went through all the processes of getting an Australian doctor. We couldn't, and we've got a doctor over just recently who's just been approved, and he has to have 6 months of having on-site supervision, which isn't ideal, but it means at the end of that 6 months he can apply to have off-site supervision, and he can then manage to do all this on his own with his supervisor at his side. It was a very big job, but it's been a long journey, but it was well worth it to know that we've now got a doctor who's going to do this for a number of years for us, and we've got other nursing homes who are waiting on the side for this to come to fruition, which we can then take on and start looking after their patients as well. We don't get as much money with the non-VR, but we do get the care plans and the health assessments, and we just think for the patients and for their needs, it's well worth the journey to do this. Next slide. So these are just little comments we've had from a lot of our patients. We've had a lot of patients thank us for letting their parents die at home or for continuing to care for them in the nursing home. But the most exciting thing that came out of all of this is that WACF was an aged care facility. It's a government-funded facility in our area, and they had a lot of closed beds. They were desperate for a doctor. They couldn't get a doctor to come on board. Our doctor had to jump through hoops just to be approved to work at this aged care facility. We went through all that process, and all those beds that were closed have now been able to open because we now can have our doctor working there, and that means that there are people who needed to be in care are being looked after in this facility. this facility has a lot of patients that have been living on the street that have nowhere to go, the mental health patients who no one wanted to take on. So we feel like we've really made a difference with this nursing home because the patients that no one wanted to care for are getting that care that they needed and the beds are open. Next one. So we're just wondering if anyone else has been doing this. Are they private billing or are they just bulk billing? Are there better ways that we can do this? Are there things that we've missed out on that could make this a better journey and improve things? You know, can anyone give us any ideas?
Yeah, look, thank you very much, Joanne. It's a really exciting sort of paradigm shifting idea. I know Richard Bills is online and he's just unmuted. I might just throw to you, Richard, does this fit with your sort of experience and do you have anything to add?
Thanks, Andrew. And Joanne, that was great. And I think really clear and sort of a simple message for people to think about. I want to just reinforce one element of that message, that is that organised, proactive organised aged care is much better and much better remunerated than reactive, disorganised aged care. And I think, having been a GP for almost 30 years, we spent a long time doing the latter and we've transitioned to doing the former, and it just makes a huge difference. I think you gave a lot of clarity about the item numbers and the organisation required to make those work for you, but I think you can make a very valuable service out of that. And in fact, some of that is about getting that critical mass. You're not seeing half a dozen people in half a dozen different nursing homes each, but actually seeing a decent sized number of people in one place at one time. We've reviewed the questions about bulk billing versus private billing. We're in a rural demographic and it's just been too problematic for us to try and explain, particularly as it's that challenge about the service provision is often delivered to someone who's not necessarily competent to make those decisions about the payment for it. And as many people doing aged care will know, we often have families who are on the chemist's doorstep because their mother or father has been charged $6.90 for a pack of paracetamol or something, and they're sort of wanting to know exactly what that's been used for. So it just sort of takes that out of the equation. Yeah, we're aware of a number of other practices in Victoria particularly who are going down the pathway of organised systematic aged care management. And I think I'd really recommend it to people.
Fantastic, Richard. Joanne, or Richard, I guess, there's a couple of questions there about sort of remote access. Do you send people out with laptops that are enabled for remote access, or how do you handle that?
We have a couple of ways of doing it. We have some nursing homes that actually allow us to do remote access from their terminals, which is good. And other ones, the doctor will do it themselves. They'll take an iPad out and they'll do remote access that way.
Richard?
Yes, Andrew, I'd absolutely echo what Joanne says. That's exactly what we've done. We have remote access in some facilities and iPads in other facilities.
The things that used to drive me mad was doing written notes in these huge old files, and then you'd have to go back to the practice and put it into medical director so everyone knew what was going on. It was double recording, which drove me mad.
So there is a little bit of an answer to that, and that is that if you put it into your program, like we use best practice, you can print it out and send it to the nursing home, so you only have to do it once and then they can put a paper file into the file, nice. The files there.
Another question, Joanne. How do you pay the nurses who do the home visits? Do they use their own car? And do they use their own car?
Yeah, they get kilometres. They use their own car, so they get paid per kilometre. And their wages, the rest of it, they're just paid their annual wage. It's just part of the job.
So they're not getting a percentage of the item number, for instance?
No. All of our nurses are employed. We have 5 nurses and 2 surgeries. We've got a smaller surgery and a larger surgery, and they get paid their annual wage, and all of them at different times are required to work at each of the surgeries and to go on road and do the visits. and that's a condition of employment. They don't get paid any extra for doing that.
All right. Well, what a fantastic and inspiring example of a problem identified, addressed, and a paradigm shifting solution, and fascinating to hear that a number of practices are going down the same route. We've got a minute or two if you do have a question that you want to shoot through that we can put to Joanne. Is there anyone else who wants to make a comment? Is the other thing. You could put your hand up and Alison can put something on the chat panel. Alison can unmute you. But I'm not seeing anything coming through, and one of the rules of these lightning lunches is that we do stick to time. Joanne, thank you so much for sharing that information. A number of people have said the slides would be valuable, and Alison has said that we can send those slides. I think we probably should send those slides around to everyone on the seminar. Alison, I suppose, if we've got their email addresses, that would be appropriate. I want to thank Alison for the work that she does month after month in making these things happen. She's very diligent. And she's also really good at it. As you can see, this has worked really well and really seamlessly.
Thank you everyone for joining us this afternoon. Have a lovely afternoon, and we'll talk to you in May.